the 13th. And this day and every Friday the 13th, at least in my time at my current employer, is that one of our paydays is on the 15th. However, when the 15th is on a Sunday and the 14th is on a Saturday, Friday the 13th is payday. And that's my inspirational message, at least for me. Thank you and have a great day.
Thank you very much, Kyle. That was great. Introduction of guests joining us today. Do we have a special guest?
Okay, next.
Okay, hearing none. I do have a special announcement regarding health and welfare. And I had it on here. We did get word that attendees at the funeral of John Mott, several of the attendees tested positive for COVID-19.
Wow.
And my message is that you were an attendee and did not know about this incident, then what I and Flint Rotary urge you to do is to see your physician or a healthcare facility and get tested, because we do have concern about your health and safety. So just get it done and stay healthy.
I have a health and welfare comment, Ray.
Okay, go ahead.
Had a long conversation with Mike Lindeman. He was diagnosed with cancer a year ago, February. No, 2 years ago, February. So this coming up now will be 2 years. And it's not curable.
Oh, wow.
Been treating in various places and even Mayo Clinic, and going to all kinds of individuals to try to find out what he can do. And it is terminal.
Mike who?
Lindeman.
Lindeman.
Mike Lindeman. So a year and a half ago, they gave him 6 months. He's still surviving. He's at home. He can carry on a nice conversation. He's limited in how he can get around. He does use a four-wheeler. He's got a tremendous attitude. And we had a long conversation also with his wife, Rita. And I asked him at the end of the conversation, could I tell you about his status? He said yes. And then I did ask him, would he like to have anybody call him? I've called him several times over this time frame, and he appreciates everyone very much. And,
Wow.
but he's run out of options, but he's still hanging in there tough. And I'm really proud of him. He's been a tremendously good friend of mine for many, many years. And we constructed Valley Woods Professional Village, so that shows how we were working together for many years. And he and Rita have planned everything out as time goes on. So again, I'm very proud to have been a good friend of him all this adult life since he came to Flint. And I compliment him for all the things that he's done in the dental profession and otherwise. So please keep him in your prayers, both he and Rotary. Thank you.
Thank you, Dick. Our prayers are with him. Wow. Thank you very much.
President Ray, I do have another health and welfare update. Joe Martin, member of our club, was diagnosed with COVID about 2 weeks ago. He's asymptomatic though, and Joe's still in quarantine, but said that every day he wakes up without symptoms, he counts it as a blessing. So just keep he and his family in your prayers as well.
Right. Okay. Thank you very much. Wow. Things are
I've
happening.
got a quick one too.
Okay.
And I don't know that she had a direct, impact on Rotary, but Joanne Piper died, and she was a longtime city worker, good friend of a lot of people in Rotary, and I've been thinking about her a lot. I went to China with her years ago with the mayor of Flint. She worked for the city. She was called the sweetheart of City Hall, and a delightful person. So say prayers for the Piper family about Joanne.
Okay. Thank you.
Ray, I do have his home number. If anybody wanted to call Mike Lindeman, he said have him call on his home line. So,
Okay.
I have that as well,
oh, okay.
the
So,
same.
so we can put that number on the screen then.
Amy, you have
Yeah.
248-620?
Yeah,
655, yeah, okay. Thank you, Amy.
you're welcome.
Wow. Okay. Next slide. Gosh. And President-elect Kyle McCree. This is our
Yes.
select.
Yep. Thank you, President Ray. For members of our club to know, as you probably know, our elections will be next month. We'll get that date settled in the next couple of weeks. It'll be via email, so that members who are not able to sign on or don't have access to the polls in Zoom will be able to vote. But this is the first reading of our Rotary Club of Flint board slate. This was nominated by the nominating committee and approved also by the current board. President will be myself, President-elect Elizabeth Jordan, Vice President Anne Marie Van Dyne, Vice President Patrick Naswell, Treasurer Stu Kelly, Director Ellen Brothers, Director Christina Church, Director Mia McNeil, Director Joe Martin, and past President Ray Gist. We'll have a second reading next week, and then we will have the election it'll either come out on the first or second week of December. You'll have a week to submit your vote. And we're doing it electronically just to make sure that everyone can participate, even if they can't, for technical reasons, get on to the Zoom. Thank you very much.
All righty. Thank you. And no, Dale, there's no electoral college.
It's electronic, so there's no hanging chads either.
Nominations from the floor, if any?
Yes.
Okay.
Our-
Go ahead.
Mike, sorry, did I miss something?
Yeah, I think you need to call for now if there's any nominations. From
Oh, thank you. If there are any or Ray, if President Ray, if you'd like to call for nominations from the floor.
Yes, if there are any nominations from the floor, please announce them now. Okay, and hearing none, this will be the slate of nominees.
Thanks, Mike.
Next slide.
President Ray, this one's mine again. Just a reminder of the challenge, the Movember challenge. There's by special request, I've added a second category to get those people who are already using their facial hair. So if there's the new stash category, and then there's the second category of those who already have a beard or a mustache. And I really consider that the new mustache side of it is really more of a skills type of a competition where you can use your hair growing skills to craft a new mustache. But then on the other side, I want to open it up for those who already have it. And I'm considering more of a beauty contest in those terms. So, you can pick which side you want to go on and still participate. So if you would like to, there is going to be, there is the PayPal button on our website. So go to that. You can make your donation. It's a pretty quick thing. You do have to have a PayPal account. And then just put a little note in there that which competition you're entering. Or if you want to sponsor, you just want to sponsor that effort, you can go there and it's a $10 fee. The proceeds are going to be split between the Rotary Foundation and the Movember Fund. And like I said, we're going to have a select group of competent judges who will select the winners in each category on the 4th, December 4th. And just another quick reminder of, your options for your mustaches. No beards here, but again, I'm working on the boxcar.
Okay, let's move on with our speaker. He's on a tight timeline.
There he goes.
And there he is. Bobby, you are front and center.
I wanted to just say, President Ray, that we're fortunate to have Dr. Bobby, our own Rotarian and entrepreneur here. He is an otolaryngologist. Yeah. And but we know him for a number of reasons. He's heading up the American Medical Association, but you know, Bobby, Dr. Bobby, as we call him on occasion, is a car enthusiast. He is a social experiment professional, because Bobby has done a lot of community work, and I'm always fascinated by his social experiments that he does. One that I know that he got on a bus and rode the bus continuously to find out how people who have to rely on that type of transportation. And he's into 3D printing. We're pleased to present him. He is a part of the state level in terms of learning to teach us, tell us more about what's happening with COVID. But Bobby, we thank you for stepping outside of your board meeting today to join us. And we applaud you for all that you are to the community and to us as Rotarians. We claim you.
Well, this is definitely home. So thank you very much for that kind introduction. So I was asked to kind of give an update on my perspective about where we are with COVID, and just wanted to share that with you, and then also just leave time for any questions. As Lynetta mentioned, so the American Medical Association board is meeting this week, and so that's the board meeting I've been in, and on my other screen on my computer here, without having to be in San Diego where we would be otherwise. So just the reality that we're living in, as all of you are living in now, on Zoom meetings and team meetings. So in this picture in the upper right, that is the virus that has made life difficult for all of us. So this is the COVID-19 virus, or it's a type of coronavirus. Coronavirus is something that's been around for a long time. This is a novel coronavirus that has a higher propensity to infect and cause more damage to tissue. But coronavirus is other types of coronavirus are the same viruses that would just cause things like the common cold. What you're looking at there is one viral particle, and it's about 100 nanometers in size. And just to sort of put that in perspective, a red blood cell, a single red blood cell, is about 70 times the size of this viral particle. And so what that is the sphere of it is a protein, and inside of that is viral RNA, which is sort of the critical ingredient for our genetic material. And what happens is that binds to a cell, usually, and through the airway is how we're getting it into us. And then that RNA gets into the cells of our body, and then our body turns into a factory to make more of this virus. And as you've heard, 50% of the time we get infected and don't have any symptoms at all because our immune system deals with it. And the other 50% of the time runs the spectrum of, a little bit of symptoms, some cold symptoms, loss of sense of smell, things like that, suggesting inflammation in the airway, all the way to, as you heard, the propensity to cause an enormous amount of death. So where we stand today in Michigan, about 250,000 cases in our state, just shy of 8,000 deaths. All regions of the state are at the highest level of alert relative to where we were just a few months ago, where the numbers had come down as we were emerging from our stay-at-home sort of orders at the state level. So, not a great time to be talking about this, given that we are going in the wrong direction. Next slide, please. So I'm not sure how well you can see it here, but I just wanted to kind of go over the types of testing. So there are three main types of testing. One of them is the molecular test, and this is what I would call the gold standard. So this is the one where people like me put a swab in your nose because the nasal cavity is where the abundance of this virus tends to be. And so if we're going to look for it and try to detect it, it might as well be at the source where there is most of it, as opposed to on your fingers or in the back of your throat or some other orifice. So that's the molecular testing. Antigen testing is sort of what I would say is the next best thing, where we're also detecting components of that viral DNA. And then the antibody testing is sort of looking for presence of our body's reaction to the virus. So antibodies get formed after we are infected by something, and there are different types of antibodies. And so what that testing does is attempts to say, whether or not we've been exposed. So the first two basically tell you if you have it right now. Antibody testing ideally would tell us if we've had it at some point in the past. So there's a lot of misinformation out there, and just a lot of confounding details about the nature of these tests. What I would want to know if it were me and I wanted to know if I had the infection right now is I would get the molecular test, which is the swab in the back of the nose, usually about a 3-day turnaround. There are some faster ways to get this. So if you're in the hospital, if you go into the emergency room and they need to know immediately or within an hour if you have it, there is the molecular test that's available for the quick turnaround, but we don't have nearly enough of it to use that for everybody. So, what I've been doing, the screening in the community, is basically the molecular test with about a 3-day turnaround. It used to be that the turnaround on that was about 10 days, actually up to 14 days at worst when we didn't have lab capacity. But now for various reasons, we've gotten better capacity to do that testing. And so right now when we do that, we get about a 3-day turnaround. The antigen test is pretty immediate results within minutes. It does have a little bit less accuracy. And so the suggestion is that you can get some false positives with that. And then so they're asking, the suggestion is that that gets reconfirmed by the molecular test. And then the antibody test is really not meant to be used for individual treatment decisions, right? So if I had an antibody test right now that said that I have antibodies to this virus, I would not feel significantly confident that I don't have to worry about who I'm with and catching it because of the inaccuracies associated with it. All of the recommendations are that that sort of testing is meant to sort of assess the immunity of an entire population. So if we wanted to say, okay, of the 500,000 people in the greater Flint area, how many of us have been exposed? We would do antibody testing to a bunch of people and say, okay, this is the prevalence of immunity within a community, but not enough to tell us what my level of individual immunity is. So it's really not meant to be used as that. It does have sort of provisional FDA approval, and it's being used for that and being sold for that. A lot of urgent cares, when you go in there to get tested, have the ability to do the antigen test, but they also do the antibody test. It is not something that's covered necessarily by insurance because, again, there's not great science to support it. But I see a lot of people just out of that crisis of confidence wanting to know any piece of information, no matter whether it's 50% accurate or 100% accurate. Any data is better than no data in their mind. So they're, paying, 100, 150 bucks a pop to get any data, even though that data is not particularly useful. Next slide. So as far as, again, types of testing, the saliva swab is the next best thing to the nasopharyngeal swab. You see that, people talk about how the testing is excruciatingly painful because people tend to, talk about going up somebody's nose. Well, you see the trajectory in this picture, it sort of follows along the floor of the nose and goes straight back. So the way it should be done is going straight back into the back of the nose. There's very minimal resistance that way relative to going up the nose, and it really shouldn't be that painful. I've been trying to train a lot of people doing testing around the community for the past several months because I had heard about how miserable this test was. I put scopes in people's nose all the time and they leave my office smiling, not crying. And so when I was hearing about the pain associated with the way this test was being done, it made me realize that people probably aren't doing it properly. So now I think people have gotten much better at it after understanding the anatomy and realizing how you go. I talk about it like a baseball pitch. You want to be low and inside relative to the nostril openings, and that's that path of least resistance. There's a typo here. Antigen testing is not actually blood testing. It's also nasal swab. Again, both very accurate, but also varies on the timing of the test. So, you have to, it's not the kind of thing that if somebody sneezed on me and was COVID positive today, I wouldn't rush off and get my nasopharyngeal swab today or tomorrow, thinking it's going to give me confidence about the result. The virus takes some time to replicate. And so I would say a minimum of 3 days after exposure would be when I would reliably expect to detect the virus in the sample. And so during those 3 days after exposure, if we knew about the exposure, then I would say, okay, well, I need to self-isolate and then get tested after 3 days at a minimum. There's some people that say even 5 days to get the the virus to the load that is detectable on these tests. Antibody testing, I mentioned, again, variable accuracy, not really recommended for individual decisions. Next slide. So you see here, there's a website. I'm happy to, I don't know, I mean, the presentation can be shared if you want, but if you just Google Michigan COVID testing locations, there's a wonderful website that you can just put in the geographic radius you want, and then it comes up with all the different places you can get tested and their hours of operation. These are just some pictures of when we were doing drive-up testing, and then the National Guard came into town, and so we helped them do tests as well. And then again, these are the PCR tests. So these are the molecular tests that take a few days to get an answer. Plenty of capacity to do this kind of testing. The problem I'm running into is that, you know, people get exposed and then they want to know immediately. They don't want to self-isolate for 3 days and then while they're waiting for the results of these tests to come back. And so they're seeking out these rapid tests. And there's nothing wrong with that, except that one, there's an accuracy issue, and two, they will sometimes get sold the antibody test and then have this false sense of fear or safety because of it. Next slide. So this is just a screenshot of sort of what that website will take you to, and it shows you all the different places. This is, you know, there's more than this in this area, but just a screenshot about the type of testing. You can also click on the little button that says no costs, or will they test asymptomatic people or not? So just sort of their own individual thresholds so that you can filter down to the exact location and type of testing and cost of testing that you might need. And so on that note, what I will also say is that, you know, weekends are not really an easy time to get tested. I get probably, it used to be about 2 or 3 messages a day, and now about 10 messages a day about people that are scrambling to trying to find out where to get tested. So I just from Quest picked up testing supplies so that I'll be able to test in my office and even out of my own home. And the only thing is, once we do this, we need to get it to a Quest location. They do keep okay at room temperature. And so if I test somebody on a Sunday and there's no Quest lab open, then I'll just take it to my office or take it to a drop box on Monday. So if anybody needs that, or you hear people that need that, feel free to point them in my direction. It's free. And you know, again, the goal is to get as many people that are COVID positive isolated so that we can sort of change the trajectory of exposure and change the narrative on it. Right now, it's out of control. We can get it back under control, but it means sort of behaving appropriately and testing appropriately. Next slide. So this is sort of where we were. So this is, you know, a graph that represents sort of the first half of the year, and it goes through June. And this, you know, early on in April was when everything was locked down because of the governor's restrictions around how we could move about. And honestly, that was wonderful because we weren't great at treating this condition in the hospital. The death rates associated with getting sick with COVID back then were much higher than they are now. And you'll see that in a later slide because, you know, when somebody comes in and they're having a hard time breathing and you check their oxygen and it says 85% and their x-ray doesn't look that good, we've been taught to put those people on ventilators, right? Give them the support they need by putting oxygen in their lungs. Now we know that that isn't a great idea with this condition because of the damage associated with mechanical ventilation on the lungs. And so we've learned a lot. And so you'll see the mortality associated with the virus has gone down, but it doesn't mean people aren't getting sick. Yes, fewer people are dying, but there's still a bunch of people that need inpatient care, right? They need oxygen, they need steroids, they need antiviral medications. And so even though the curve has changed, the narrative is still very concerning. Next slide. So, you know, again, when the numbers started to go down, initially there was no elective medical work being done. You know, all of that deferred care for cancer screening and all these things were sort of put on hold because we didn't want to run out of PPE, you know, the gear required to do these procedures and hospital beds associated with it. So this is, you know, this is me happily announcing next to the governor that elective medical care could resume after we made it through that initial phase and the numbers got better. And then next slide. And so now you see where we are, right? So after that low through the late summer and early fall, now we are back up even much higher than where we were before. The peak looks the same, but the scale is different. So this peak is at 5,000 cases per day. The peak on the previous slide was 1,500, right? So we are detecting a whole lot more. And so one of the things that I had heard was that, well, we're finding more because we're testing more. Well, that's absolutely true, except that testing more doesn't mean making more people sick. And the fact that hospitalization rates are going up really clearly refutes the theory that, oh, it's just that we're testing more. Testing more should show a lot more asymptomatic or not sick people. But when you're testing more and the numbers are going up as far as hospitalizations, that's not just simply due to testing more. Next slide. And so this sort of reflects what I mentioned earlier, the death toll initially, as far as deaths per day, we were, well above 100 deaths per day. And now we're at less than half of that because, again, one, we're getting better at treating this disease. And two, the nature of the people getting sick is different. At the beginning, a lot of elderly, a lot of people with compromised immune systems, those are people that are going to have a tough time with this infection no matter what. But now we're at the point where it's sort of the general public. It's people like you and me getting sick with it, where we aren't dying at nearly the same rate, but again, still requiring care. Next slide. And so that brings us to the new issues related to capacity. These are headlines just in the past 48 hours or so about what's going on in area hospitals. Hurley Hospital at 98% capacity, Western Michigan hospitals sort of, setting records, filling up. This memo here is from Ascension that just came out to all the physicians on staff a couple of days ago that basically said we're going back to the point of not doing elective procedures that require a stay in the hospital, right? So, I can still take out, people's tonsils because those people are meant to go home. But somebody that's coming in for a procedure, like a abdominal procedure or something like that, that would otherwise stay for a night or two, all of that stuff is on hold now because of bed capacity. And then you see the graph on the far right, COVID hospitalization rates soaring. So again, not people in the ICUs necessarily needing ventilators, right? So we're not going to have to find 2 million more ventilators for the country, hopefully, because that's not the nature of these admissions. These are admissions that we're sort of seeing on our social media posts about people we know that just need to go in, get steroids, get oxygen, and get antiviral medication, and then leave. But you can't just put somebody like that next to somebody that's there because they have an infection of their foot that isn't COVID positive. You have to sort of create a COVID unit to take care of them. And that's really sort of creating a capacity issue of where do we put a group of rooms within a hospital to protect other people from these patients and take care of these patients in a way that's safe for them. And then the other thing is nursing staff. So next slide. So this is a nurse that pretty much taught me everything about surgery that I didn't learn in residency. Santa Staples was an OR nurse that worked with me at McLaren for almost 20 years of my practice. And she passed because of COVID just this past week. And this is a picture from her memorial service. But I put it in here to highlight that our healthcare workforce, as we become COVID positive, taking care of patients that have COVID, is dwindling. So not only do we have a higher demand for resources, we have a lower supply of people to take care of those patients. And it's just a terrible combination. I've seen numbers from 1,500 to 2,000 healthcare workers that have been lost because of COVID. Next slide. And again, this just is a map to illustrate that we are not alone. You see that the major shade on this map, the sort of the brick red, is what we would categorize as uncontrolled spread. So this is a map that's 2 days old and trending poorly. And I guess, there's no place that's trending better. And the best place is sort of in the Northeast. I always forget if that's Vermont or New Hampshire there, but that's the place to be. But I don't think that's going to stay that color for long. So as far as, next slide, as far as sort of what to look forward to, there's sort of two ways that we can emerge happily from this. One is herd immunity. If 90% of us develop antibodies, we're now, like smallpox, for example, there's, it's not something that's going to spread because we have herd immunity, because 99% of people on the planet are immune to it. But that will come at a cost, right? If we expect herd immunity to solve this problem for us, we are going to see twice the number of deaths to get to that point. And it's an enormous price to pay to just say, let's just get as many people sick as possible and put people in gymnasiums and arenas and stuff like that to take care of them and get to herd immunity. It is not a logical solution to this problem. So that leaves us with vaccines. We've seen a lot of positive developments just in the past week as far as the promise of vaccines with the 90% efficacy with the Pfizer one and Moderna releasing its numbers pretty soon. We talked a little bit about this in our breakout room earlier today, as far as how long will immunity last. I would predict that this isn't going to be like chickenpox, where we have immunity that's going to last a lifetime. It's probably going to require a booster, more like tetanus, where every 10 years or so, we might need a booster from it. But again, that can all change. We're still very early, and this is mostly conjecture on my part. I suspect that we will have a vaccine that will be broadly available probably in the first quarter of next year. And people that are high risk will get it first. So the elderly, people with chronic disease, healthcare workers, which means that probably 6 months from now, before sort of everybody else will have access to it, which means we have, close to 8 more months of trying to live very smartly to minimize the number of deaths. Next slide. So what do we do in the meantime? It's not rocket science. It's basically preventing the spread of these microscopic viral particles. People talk about how the virus is so small that it's just going to go right through the mask anyway. Well, it's also a question of viral load. If there are 1,000 particles that get sneezed out of somebody with a mask, and 50% of them make it through that mask, and another 50% make it through your mask. So now we have 250 viral particles from that sneeze that make it through your mask. That's a heck of a lot easier for your immune system to deal with than 1,000 viral particles. So masking is critical for this. Avoiding unnecessary gathering, the distancing part of it. And I'll just say that we enjoy our freedoms. Social media has been sort of, replete with debates about the freedoms we enjoy in this country. But having that freedom brings with it responsibility, dining out, all these things that we should practice that freedom with restraint and responsibility and concern, not just for ourselves, but with our fellow man. And so, now is not the time to be doing things like dining out and, that sort of stuff. That can wait when we don't know what the hospital capacity is going to be. We've already seen one of our 3 area hospitals close down elective work, essentially. This next week is going to be very telling about it. And so that's why, now is not the time to be taking that risk. I don't want my dining out less than responsibly to be the reason somebody has to suffer with a painful gallbladder and gallstones because they can't get that out because of where we are with our hospitalizations and our elective care. And so I'll stop there. Happy to answer any questions. I'm an eternal optimist. I hate giving a talk like this that portends worsening ahead, but that's the reality. I do think we will emerge. If we live responsibly, we will emerge happier than if we don't.
I have a question from Jerry Preston. It just went off. Just a second here. If you think you have been exposed, you need to get tested. But what can we do to reduce the severity of the infection?
Yeah, so if you've been exposed, there's really not much you can do at home, self-care wise, that will keep you healthier. Other than, nutrition, hydration, that sort of thing. It's not like there's no data to really show that, oh, I better start loading up on vitamin C and I'm going to stop this virus from replicating. I've seen all sorts of theories about that, but nothing that we can point to scientifically is saying this is what we should do at home to minimize the effect of this virus that's inside me and growing right now.
Okay. More questions?
I got a question here, Ray. Hey, Bobby, as far as getting tested out in the community without having any symptoms, just to kind of continue to, I would say, clear the air. How often would that be appropriate to do that? If, and I'm talking about like when you're out there, you're just calling out and saying, I'm offering free testing at X and Y site.
Yeah, yep. So, you know, if right now we have the capacity to test anybody that wants to get tested, my answer to that would have been different when tests were not nearly as available. I would say, you know what, do it once out of curiosity, but don't go back monthly because we need those tests for other people. We have an abundance of tests right now, and hopefully it stays that way. So to answer your question, I would say, you know, do it to find out if you have it now, that's fine. If you are at home practicing social distancing, not really exposed to anybody, there's no reason to get that test again anytime soon, right? If this is how you're living and you're not in meetings or having to go to the grocery store regularly and interacting with other people, you don't need to get tested again for weeks, if not months. But the nature of your and I's life is that we will be around people, right? I see patients, I'm still seeing, you know, 20 to 30 patients a day who are coming in for stuff that can't be put off because they want to know if the lump in their throat is cancerous or not. So I'm exposed. And so I'll be getting tested every couple of weeks to stay ahead of it.
Okay. I have a question from Mia McNeil. So when do you think we will safely have large gatherings again? And do you think we will move toward a nationwide shutdown?
Yeah. So the first question, large gatherings. So when could we put 100 people in a room shoulder to shoulder? Not till the second half of 2021. You know, and I think it'll be a vaccine that gets us there, right? And so until enough of us are vaccinated, I don't see that happening until then. So like the meetings that I would, like the one I'm supposed to be in November, where there's 1,000 physicians in an auditorium, I fully expect the June of 2021 meeting of the American Medical Association to also be virtual for that very reason. And I thought there was another part to that question.
No, nationwide shutdown.
Yep. So, I mean, I think that, you know, that I showed you the map where the entire country is in the same sort of category. But within that, you know, if you're in rural Nebraska and the incidence of the disease in your town is low, even though Nebraska as a whole is that dark red, I don't necessarily think that you need to be under the same restrictions as the people in Flint, Michigan, where the prevalence of disease is different. So as far as a nationwide shutdown, I don't see that happening. I still think that we can tailor it based on the data in a given community, not even just a given state, but a given community within a state. If the UP ends up doing much better than they are right now, then yes, just like they were released earlier, they can be released earlier again. So I don't see a nationwide shutdown, but I do see a lot more shutdowns across the nation based on prevalence of disease in a given area.
Okay. You have a compliment from Dale Wayhill. I can say firsthand, Bobby has a great bedside manner and a gentle touch with the nasal swab. I really appreciate him. And that was for you. And also one from Elizabeth Jordan to everyone. I feel torn now because my kids attend a hybrid school a couple times a week with small cohort classes, social distancing, and mask wearing. Their school has all the protocols in place they could possibly have. Yet, according to the World Health Organization, Harvard, and other public health places, Michigan's current data indicates schools and many other places should be shut. How safe is it to continue sending kids to school?
Yeah, I mean, I think that this puts the policymakers in a tough position because they use the school in its broadest sense, right? So they're talking about schools that do things perfectly to a T, and they're talking about schools that are quite on the opposite end of the spectrum about the care that's being displayed there. Whether it's because of resources or whether it's because of will, that's an entirely different conversation. And so I think that what you hear about those guidelines is based on the overall conversation about schools in general. If I ran a school and was screening everybody for symptoms, and I thought I had a parent population that was with me philosophically about how to approach this disease, I mean, I was witnessing conversations between parents in denial about the prevalence of this disease and its severity and principals that were trying to do the best for their kids. That is a bad combination, and that school probably shouldn't be open because things will fall through the cracks. But if on the other hand, you're in a school where everybody is seeing eye to eye and shares the common goal and vision for safety, then yeah, I think a school like that probably could stay open. But I think they're hard to find. I mean, it sounds like you might have one there, but they're not the norm, I would say.
Wow. Okay, from Jane O'Dill. So I haven't been tested at all, nor have I been around anyone who has tested positive that I know of. So should I have the test?
Yeah, no, I mean, for you, it would be purely curiosity. And the chances of you having the swab test for the molecular test that is most accurate, the odds of you having it, if I happen to put the swab in you today, is very low. It would be purely for curiosity. So should you have it? No, not unless you feel like you might have forgotten about a contact, or other people that aren't as careful might have, but, and again, it's not just a fleeting passing by in a grocery store aisle where you inhale what somebody has exhaled in the 2 seconds that it took to pass. That's not what's going to put you at risk. It's your conversation with that person face to face, even with the mask on, that's going to go on for 10, 15 minutes.
Right.
That's where all of a sudden you have some risk. And so if you find yourself in that situation, then get tested. But if it's just a fleeting sort of passing by with other people, regardless of their COVID state, you're at very low risk, and I wouldn't get tested.
Okay, very good.
I have
From Joel Fike. When the vaccine arrives, how will we get it? Do you think there will have to be a massive sell job to get people to take it?
Yeah, so I mean, as far as how you would get it, you would probably get it through the health department. The vaccines that I'm seeing now require a much lower degree of much colder temperature of refrigeration than traditional vaccines and other medical equipment. And so how will we get it? Well, it's going to be from places that have that sort of refrigeration system. We don't have it in our offices. Most offices don't. Health departments probably will get them if they don't have them. Hospitals. So that'll be the institution type from where you will get the vaccine. And then, I'm sorry, there was another part to that question. How much of a sell job? Well,
right.
So that's where sort of the politics comes in. Clearly, there's a crisis of confidence that's arisen from the division that I've witnessed across the country as far as the reality of this virus. And with that comes doubt about the efficacy of vaccines and the safety of vaccines. And what's interesting is I'm seeing it on both ends of the political spectrum. Those people that feel like the disease itself is no different than the flu. Why should I even get a vaccine? I don't even get a flu shot. To those people that feel like things are being rushed and the development is being hastened through without strict protocols, and therefore they don't trust it, whereas they would naturally get a vaccine in other situations. So you have sort of both ends of the philosophical spectrum about what this disease means to our society that are doubting the vaccine. And that's not a good position to be in. So it will take a lot of robust data and a lot of messaging from people like me and organizations that I sit on, like the American Medical Association, to convince people about the safety and how the process was separate from the politics of it.
Okay. From Lynetta Coney. I have to make an essential airplane trip during Thanksgiving, and I am a bit nervous. My family said they will go with me. Shall I make them stay at home and go solo?
Right. So there's no reason for them to go with you to give you comfort when all it does is increases the risk of them getting infected. Right.
Okay.
So when it comes to the infectious disease sort of opinion about this, the fewer people that have to do a risky behavior, the better. How risky is it? I think there's a lot of variability. I flew once to Atlanta for something during all this, and it was at the low point. And I flew on Delta, who's done a very nice job of trying to keep us safe as air travelers during this. From what I've heard about other airlines is quite different. So I would say it depends on the carrier and their philosophy about it. The fact that Delta is willing to turn a plane around and land it if somebody takes off their mask, I think is the right way to keep people protected on that airplane. And so if you have to go, then you should. But I would sort of research who you're flying and what their philosophy is. And I wouldn't take anybody with you that doesn't have to go.
Very good. Okay, from Mia McNeil. How often should a mask be reused and washed?
Yeah, so I mean, it's a good question. We're having to reuse a lot of masks just because of supply, like the N95 masks. Those were sort of single-use sort of things before. Now people are using them for a week. Depending on exposure. So I use a disposable mask when I'm in the office, and I change it every day just because that's a high risk thing, right? I'm literally inches from somebody's nose and mouth as I'm working on them. And so there's a high likelihood that somebody in the past week has been positive, and that's not a mask that I want to reuse. But the cloth masks that we're going to a grocery store with, and we're not within 6 feet of people, I mean, those, I would say, just wash those once a week.
Okay, excellent. Those are all the questions that I have written down. So
I have a question, Ray.
go ahead.
First of all, I want to apologize. I was called away for several minutes. So Bobby, I didn't hear your presentation until about 10 minutes ago. My question is this. We're 89 and 90 years old. We have our temperature taken every morning, and it's been normal ever since we started last March. If either my wife or I have an elevated temperature of 100 or more, what would you suggest we do?
Yep, so you should get a COVID test, because if you have a fever, that means that, or an elevated temperature, even if it's not above 101, which is what we traditionally call a fever, then you should really make sure that it's just a common cold and not the COVID virus. So if I were you, I would get tested if you have a fever.
And where do you go to get tested? My intern?
So, yep, in my presentation, I think it can be forwarded around if anybody wants. There's a link, but if you just Google Michigan COVID testing site, you can put in your zip code and then the radius if you're willing to travel 10 miles or 20 miles, and you'll get a whole list of places. And if it's something urgent and you can't get tested, like I said, I've got all this stuff at my home. Heck, I'll come out to your place and put this up your nose gladly if you'd like, and send it over to Quest to get processed. We'll bring back the house call.
Thank you very much. First house call I had was when I was born. It cost $5.
This one will be free, but you won't like it as much.
I have a question if you've still got a minute.
Yeah.
Go ahead.
So I've been following and updates from the CDC, but I'm wondering if you've seen anything recently on the how pregnancy is affected by COVID. I know that can mean different things based on where you are in pregnancy, but just in general, if you have any information in that.
Yeah, there's not a whole lot of data there. And so as far as sort of risk to the baby in utero, thankfully, the younger population, the student population is not as susceptible to the bad outcomes associated with this virus. And so you can extrapolate from that and probably and say that, neither would a newborn baby or in utero child. But again, that's a little bit speculative. They do have the immunity that's conferred to them through the placenta. The antibodies travel through the placenta. There's a particular type of antibody that does. And so should you be cautious? Yes, but not to the point of doing anything you shouldn't be doing otherwise, to protect yourself.
Okay. I've got one last question, then I have a comment. From Jerry Preston, how well does the Michigan COVID Alert app work?
I don't get alerts on that, but I guess if the degree of involvement of MDHHS in this virus and its management is any indication, then I would speculate that it works pretty well. I've been very impressed with the state resources as it relates to testing and alerts. They're on calls every day, and once a week I've been participating when my schedule allows me to. So again, I don't have experience with the app in particular, but I've been very encouraged and confident in the efforts of the state.
Oh, thank you much. And a comment from Elizabeth Jordan. Thank you very much, Bobby. Your calm, knowledgeable approach is a steady anchor in a choppy sea. And I want to personally and
I think that's another way of calling me dead weight, but thank you, Elizabeth.
Thank you very much for taking out the time to come and give us this information that is current, vital, and really essential for all of us to have. The Rotary Club of Flint will make a donation in your name to the Rotary International Foundation for the eradication of polio. Thank you for joining us today, and please keep joining us as often as you possibly can.
Absolutely. I just put my cell number in there. If anyone needs to text me, if they need a test and just are having a hard time finding one, I'm happy to help.
All right, we appreciate it. I want to thank you for that inspirational message. I want to thank Kyle McCree for his inspirational message and Dr. McCumula for his factual and educational presentation. Flint Rotary thanks each and every one of you for joining us today. I hope you enjoyed our program as much as we enjoyed having you join us. I'm inviting you to join us next week to see and hear Ms. Victoria Zapsky. She will discuss the status of the environment and recycling activities on this beloved earth. Be safe, stay warm, and look to open opportunities in order to provide service above self. Have a great weekend. And we are adjourned. Wow, that's a nice sound now. When did you fix that bell? It's been sounding good now for the last, what, 3 or 4 meetings?
Yeah, just move the knobs up and down. It seems to work all right.
Good job.
Have a good weekend, everybody.
Bye-bye.
Thanks.
Bye-bye.
Bye-bye. Wow. That was good.
Yeah, we had a really good turnout. Really
Right.
happy with that.
So I guess if you don't really have a temperature, or if you don't feel any urgency, then you don't really have to get a test right now.
Yeah, or if you're not exposed to anybody.
Right. But if things change, then it's a good idea. I've
Yeah.
been going to my own physician. He does the test.
Oh, yeah.
But
Ray, George, is it possible to put Bobby's presentation on our website, Rotary's website?
Well, so what we did is we record each one of these sessions, and then
Good.
we move that recording out to our YouTube channel. So if you go to YouTube and you type in Rotary Club of Flint, it'll come up and it'll show the different presentations that are out there.
Good.
This one might take a couple days to get out there because we have to move it from one spot to another, but I'm sure by early next week we'll have it out there.
Thanks, George. Appreciate that. I thought it was an excellent presentation. Other folks ought to hear it.
Yeah,
Thank you.
we're lucky to have some pretty talented people within our club. That's for
Boy,
sure.
indeed. Indeed, that is true.
so George, when I pay my $10 for the mustache contest, what if I just use a photo of a mustache that I had about 25 years ago?
Well, there's not too many rules, so I'll leave it to the judges.
All right.
It didn't
I
even-
remember that.
Yeah, it didn't even say it had to be a real mustache. That's why I was hoping some of the ladies might join in with a fake mustache, but we'll see what happens.
Okay. Well, thank you much for all the work
All
you do.
No problem. We'll
And
see
we
you
will
next week.
All right. Sounds great. Bye-bye.